Hi friends, this is the normal appearance. This is the patient showing stroke causing isolated left lower facial weakness. There is flattened nasolabial fold and inability to smile on the affected side and with sparing of forehead and eye closure muscles. Here, Bell's palsy with upper and lower facial weakness where there is involvement of the forehead region also with mouth deviation to opposite side. Features of Bell's palsy. Sudden occurrence of paralysis of one half of face. Forehead cannot wrinkle on the affected side. Eye on the affected side can't be closed due to which tears rolled out. Angular mouth pulled towards the normal side. Talking, chewing is difficult. On closing the eye, eyeball rotate upwards. 80% recover in 1 month and 10% in next 6 months and remaining will have residual paralysis. If the facial weakness is also isolated to lower face, stroke is the most likely diagnosis. Look for associated signs and symptoms. So brainstems have multiple cranial nerve nuclei. So we have to look in case of stroke. What are the other signs and symptoms? Weakness or numbness in arm or leg, slurred speech or dysarthria, double vision or diplopia, and facial numbness due to trigeminal nerve involvement, difficulty in swallowing or dysphagia. So incoordination, ataxia caused by damage to brainstem or cerebellum, and vertigo, perceived movement of spinning sensation in case of cerebellar and brainstem stroke. So, incoordination ataxia tested by finger nose testing. Treatment of Bell's palsy, tablet prednisolone, 1 milligram per kg per day for 5 days. If present, patient presents within 1 day. Oma is a 20 milligram OD for 1 week and neurobion injection IM on alternate day and CMC eye drop and message on the affected side of face with olive oil 3 times and consult physiotherapist. Acute headache. Headache is few hours to few days and not recurrent. Is acute headache. If headache is the only symptom, give aspirin 300 TDS and diclo IM stand and rest in dark room and observe for other associated symptoms. If headache is the part of other infections like ERTI, viral fever or malaria, give specific treatment. Headache which cause the loss of vision in case of glaucoma or temporal arteritis. Temporal arteritis present with severe unilateral temporal headache in the elderly. And we have to rule out life-threatening headache like meningitis and subarachnoid hemorrhage. Meningitis, there is severe headache with high-grade fever and vomiting. On examination, neck stiffness will be there. And subarachnoid hemorrhage, sudden onset of splitting headache described as worst headache in the life and vomiting is present, fever is absent. Loss of consciousness usually follows the neck stiffness is present. So, tension, headache, meningism, raised intracranial pressure, malaria, dehydration, carbon monoxide poisoning, altitude sickness, post-concussion, malignant hypertension, subarachnoid hemorrhage, cervical spondylosis, stroke, glaucoma, trigeminal neuralgia, giant cell arteritis, and drugs like nitrates and preeclampsia. These are all cause headache. Central nervous system, critical cases, subarachnoid hemorrhage, carotid dissection, venous sinus thrombosis. Emergent cases like tension, traction headache, and tumoral mass, subdural hematoma, shunt failure. Non-emergent migraine, vascular headache, trigeminal neuralgia, and post-lumbar puncture headache, and post-traumatic concussion. Toxic like carbon monoxide poisoning or mountain sickness. Collagen vascular disease like temporal arteritis is critical. Ocular glaucoma and sinusitis, dental and TMJ problem. Musculoskeletal tension headache and cervical strain. Allergy like cluster or histamine headache. Infectious disease like bacterial meningitis or encephalitis, brain abscess and febrile headache and non-neurological source. Pulmonary or oxygen anoxic headache, anemia and cardiovascular hypertensive crisis and unspecified preeclampsia. Next is chronic persistent headache. Chronic persistent headache is mostly due to migraine. Headache of few days or few months in duration without headache-free interval in between. Examine for evidence of raised intracranial tension or brain tumor. If there is vomiting or fever or disturbance of vision or paralysis, then we need MRI scan. Tension headache is muscular contraction headache, maximum over the vertex, increases in the evening and advice regarding stress reduction and reassure headache that is harmless. Mild analysis like paracetamol and aspirin can be given and tablet amitriptyline 10 mg HS given, but if headache doesn't subside with it, increase dose to 75 milligram HS. Avoid tranquilizer and antidepressants. Next, chronic persistent headache is sinus headache. Sinus headache is unilateral associated with symptoms of ear, tenderness of frontal and maxillary sinus, maximum in the morning. Steam inhalation and amoxicillin 500 TDS or cefotroxyl 500 BD for 7 days. Analysis and X-ray score to be taken if there is no response. If haziness is seen in X-ray sinuses, then refer to ENT for drainage of sinuses. Hyperacute is thunderclap headache, CT scan or lumbar puncture. So subarachnoid hemorrhage, bleeding AV malformation, and ruptured AV, ruptured perianeurysm. Acute episode of single recent head trauma, if it is there, epidural and subdural hematoma confirmed by CT scan. Acute recurrent, if it is associated with nausea, photophobia, aura is present or absent, we will common or classical migraine. Associated with excruciating unilateral pain, pain primarily in trigeminal neuralgia in case of fifth nerve distribution, and focal neurological deficit is complicated migraine, and aura present or absent, classic or common migraine. Acute single episode of headache, but no trauma, fever is present, nuchal rigidity present, meningitis, alternative status and seizure is present, encephalitis, and if there is no fever, fundoscopy, look out for blood pressure. Eye strain headache, headache occurs in evenings, and after straining the eyes after reading and seeing, and we have to do the refraction. Chronic persistent headache. So chronic persistent headache is usually migraine. So in case of migraine, pain on sides of the head and intense pulsating or throbbing type of pain associated with nausea or dizziness can last for days, and associated with flashing of lights and blind spots, and commonly recurring. Chronic persistent headache, uncommon or classical migraine. Patient gets aura followed by throbbing unilateral headache, which is terminated by vomiting. Common headache is patient doesn't get aura and headache is mild and generalized but recurrent. Hence, patient doesn't approach doctor unless headache is severe, but goes on taking crocin or paracetamol whenever required. Chronic recurrent headache, for all practical purposes, migraine is the only cause of chronic recurrent headache. When attack is mild, give paracetamol and metoclopramide 1 to 2 TDS, still headache subside. Rest in quiet and dark room. Paracetamol plus ibuprofen if pain doesn't stop in 2 hours. Amlodipine 400 injection Poveron 2 ml IM SOS. Migraine that is mild to moderate, simple analgesic like aspirin, acetaminophen with antiemetic, and combination analgesics and caffeine can be given. If it is inadequate response, manage as severe migraine. Associated with nausea, vomiting, or diarrhea, add an antiemetic. Inadequate response, consider preventive therapy. Severe is triptan, DHE, nasal spray, inadequate response, CGRP antagonist, selective 5-HT, 1F agonist. When attack is severe, there is severe migraine headache, tablet ergotamine migrainil 1 milligram, 2 tablets statin, 1 tablet every 30 minutes. Till attack stops, maximum 6 tablets in a day, or sumatriptan 50 mg stat, repeated after 2 hours, till headache stops. When attacks are very frequent, tablet propranolol 40 mg TDS for 3 months, or amitriptyline 10 to 25 milligram night time for 3 months. Flunarizine 10 to 20 milligram OD for 3 months. Longer duration of headache, if it is there, more safe it is. So acute headaches are always dangerous. Don't blame the impacted molar, cervical spondylosis, constipation as the cause of the headache. Hypertension causes the headache only when the diastolic blood pressure is more than 120. Alert for subarachnoid hemorrhage or meningitis in case of headaches. And small cylinder refractive error correction is responsible for eye strainer rather than large error. And myopia will never cause the headache. Thank you.
This timing. Don't be desperate. Don't act desperate. Don't rush. Don't panic. Don't believe anything other than God is in control and it will be His perfect timing. Maybe you're lonely. Well, maybe God wants you to be lonely so that it would push you towards Him. He's a jealous God, wants no competitors. If you could write this down, not just on paper, but write it on your heart, it would serve you well. Your goal is to figure out whether you can both serve Christ better together than apart. Simple.